Chronic renal failure. Chronic renal impairment is the irreversible loss of glomerular filtration rate, GFR. This is important for two main reasons. There may be direct consequences of impaired renal function. Loss of GFR tends to be progressive, ultimately leading to end-stage renal failure. Normal young adults have a much higher GFR, approximately tenfold, than that needed for life, so substantial decrements in GFR often cause few, if any, symptoms. NB. Do not dismiss a slightly elevated creatinine level as a minor problem. In chronic renal impairment, lost nephrons cannot be recovered and an elevated creatinine score represents a loss of about 50% of GFR. Etiology and pathophysiology. Diverse primary processes result in the loss of GFR. The following are the most common causes in the UK. Diabetes mellitus. Glomerulonephritis, most common is IgA nephropathy. Congenital dysplasia/chronic pyelonephritis/reflux nephropathy. Obstructive uropathy. Autosomal dominant polycystic kidney disease. Vascular disease/hypertension. Loss of renal function tends to be progressive, probably as a result of the following. Continuing loss of nephrons from the primary process, e.g. glomerulonephritis. Glomerular hypertension in remaining glomeruli, which increases GFR per nephron but in doing so leads to loss of further nephrons, the hyperfiltration hypothesis. Epidemiology. Normal GFR in the population varies with age, falling as patients get older. Since muscle bulk, and thus creatinine production, also decreases with age, the normal range for plasma creatinine remains the same. An elevated creatinine will be outside the normal range of GFR at any age, and usually represents a loss of about 50% of GFR. In elderly people, a slightly elevated creatinine may represent a GFR of 30 ml/min. Investigation and interventions need to be considered in those who are outside the normal range for GFR and have risk factors for progression, hypertension or proteinuria, or when renal function is changing, even if the absolute value lies within the normal range. Table 12. Prevention of progression is clearly most effective if started early, well before there are any symptoms attributable to renal failure. Clinical presentation. Most often with the incidental finding of a raised creatinine, abnormal urinalysis, or hypertension. Sometimes with symptoms related to underlying process, e.g. macroscopic hematuria or outflow obstruction. Symptoms and findings attributable to loss of renal function are often present in those with more severe renal impairment, but they are relatively nonspecific, e.g. fatigue, anemia and disturbed taste. A significant number of patients will have previously unrecognized end-stage renal failure at presentation. NB. Signs and symptoms pointing to chronic renal impairment rather than acute renal failure are commonly quoted but are very unreliable. Assume that any patient has acute, i.e. potentially reversible, renal failure until you can prove that it is chronic, for example by finding a blood test showing a similar level of renal function months or years previously, or reduced renal size. Symptoms attributable to loss of renal function usually only occur when there is severe renal impairment, GFR less than 25 ml/min. This has two implications. Check creatinine in high-risk populations, people with diabetes or hypertension, or those with protein or blood on a dipstick test. In patients with moderately elevated creatinine, less than 300 mol/L, symptoms need another explanation. Investigations. To guide interventions. Biochemistry, potassium, creatinine, calcium, and phosphate. Hematological parameters. Identify cause of renal impairment. If possible, Identify the cause of renal impairment, especially treatable conditions. All patients should have urinalysis and microscopy, renal ultrasonography. Further tests are guided by these and the probable underlying cause in the particular patient. The choice of tests is also influenced by whether or not a treatable condition could be identified. Older patients should usually have serum and urine electrophoresis. Patients with normal-sized unobstructed kidneys without scars should usually have a renal biopsy. Those with small kidneys should usually not be biopsied. The hazards are substantial and no useful information can be obtained. Monitoring renal function over time is important. Once creatinine is elevated, usually indicating loss of about 50% of normal GFR for age, serum creatinine alone gives a simple and reliable measure. Some drugs, e.g. trimethoprim and cimetidine, decrease creatinine secretion, causing a reversible rise in plasma creatinine. This can be mistaken for a deterioration in renal function. NB. Once an individual's creatinine is elevated, this gives a sensitive and straightforward indicator of changes in renal function, and it is not usually necessary to measure creatinine clearance. This avoids the inaccuracies and inconvenience of 24-hour urine collections. Many patients fail to collect all urine for precisely 24 hours. If you try it for yourself, you will understand why. Often a reciprocal plot of creatinine against time is linear, representing a constant rate of loss of GFR. This plot is useful in predicting when end-stage renal failure is likely to be reached, determining whether a new value of creatinine is consistent with the expected trend. If a new value indicates a faster than expected deterioration, it may prompt a search for another cause, e.g. prostatic obstruction, urinary tract infection or an NSAID. Complications and treatment. Aims are to prevent progression of CRF, prevent secondary complications. Where possible, the underlying cause of the renal damage should be treated or corrected, e.g. analgesic nephropathy, systemic lupus erythematosus, paraproteinemia. Progression of CRF. As stated previously, irrespective of cause, there is a tendency for CRF to progress. NB. The amount of proteinuria correlates well with the risk of progression of CRF. Many interventions alter the course of CRF in animal models, including the following. Antihypertensives, especially angiotensin-converting enzyme, ACE, inhibitors and angiotensin receptor blockers, ARBs. These have a preferential action on the efferent arteriole, lowering glomerular pressure more than systemic BP. Protein restriction. Lipid-lowering agents. Antiplatelet agents. Immunosuppression. NSAIDs. Antihypertensives, particularly ACE inhibitors and ARBs, are the only treatment that has been proved to influence the progression of CRF in convincing clinical trials in humans. In diabetics, good glycemic control should be encouraged. Successful pancreatic transplantation has been shown to reverse the histological changes of diabetic nephropathy. Antihypertensive agents. Diabetes. In one study, 409 patients with type 1 diabetes were randomized to captopril or placebo. Other antihypertensives, but not calcium channel blockers or other ACE inhibitors, could be added. After 4 years of similar BP control, the group given captopril had a slower rate of increase in plasma creatinine and less likelihood of end-stage renal failure or death. In those with creatinine greater than 132 moles/L, the annual rate of rise in the placebo group was 123 moles/L versus 53 moles/L in the captopril-treated group. Importantly, there was benefit in normotensive patients. In nephropathy due to type 2 diabetes, the largest trials have been of ARBs, which were shown to protect renal function, renal and IDNT studies. Non-diabetic CRF. The modification of diet in renal disease was a 2x2 study of 840 patients that examined the effect of protein restriction. It also compared aggressive and standard BP control. Achieved mean arterial pressure in the groups was 91 and 96 mmHg, corresponding to 125/75 and 130/80 mmHg, respectively. The benefit was greatest in those with more proteinuria, greater than 3 g/day, and moderate renal impairment. Subsequent large randomized trials have shown that ACE inhibitors offer greater protection of renal function compared with placebo or other antihypertensive agents in patients with significant proteinuria, e.g. ramipril efficiency in nephropathy trial. There is some evidence for further benefit with the addition of an ARB to an ACE inhibitor, Cooperate study. Controlling BP is the only intervention that has been proved to slow the progression of chronic renal impairment in humans. In patients with heavy proteinuria, greater than 3 grams per 24 hours, a BP of 125/75 mmHg is more beneficial than one of 130/80 mmHg. Hypertension. A high proportion of patients with CRF, 80% as end-stage renal failure approaches, will have hypertension. Treating hypertension slows CRF progression, especially in those with proteinuria, and is also presumed to reduce cardiovascular risk. Treatment strategy. When planning, remember the following. Most patients are salt sensitive, so it is appropriate to decrease salt intake. Many patients will require multiple antihypertensive drugs. The first choice antihypertensive is an ACE inhibitor, based on animal studies and studies of people with diabetes, except in those with renovascular disease. Loop diuretics, e.g. furosemide, are useful adjunctive agents, especially if there is evidence of sodium overload, edema. In patients with proteinuria greater than 3 grams per 24 hours or diabetes, the target BP should be less than 125/75 mmHg. Hyperkalemia. Hyperkalemia will cause symptoms only at near-lethal levels. Serum potassium should be monitored by blood tests, not symptoms, and, acutely, ECG. Treatment strategy. Plan as follows. Dietary restriction of potassium intake, Table 13. Avoid potassium-sparing diuretics. Consider changing from ACE inhibitor/ARB. Correct acidosis. In diabetes, improve diabetic control. For emergency management. Acidosis. Metabolic acidosis is usually a clinical problem only at or near end-stage renal failure, and may contribute to feelings of malaise and breathlessness. It is identified and monitored by measuring venous bicarbonate. Treatment strategy. Remember to take account of the following. Avoid excessive protein intake. Consider oral sodium bicarbonate, but a sodium load may exacerbate hypertension. Some patients will need dialysis. Bone and mineral metabolism. As CRF progresses, phosphate excretion is insufficient and plasma phosphate rises, stimulating parathyroid hormone, PTH, secretion. Also, 1-hydroxylation of vitamin D, proximal tubule mitochondria, is impaired, which depresses PTH. Reduces calcium absorption and serum calcium, further stimulating PTH. Consequences of elevated PTH. In normal individuals this produces marked phosphaturia. However, in those with CRF this does not occur and phosphate rises as a result of increased bone turnover, further stimulating PTH. This results in the following: bone loss and risk of fractures, progressive parathyroid hyperplasia, and eventual autonomy, itching and calcinosis cutis, pyrophosphate arthropathy. Treatment strategy. This should include the following: dietary restriction of phosphate, phosphate binders, e.g. calcium acetate before food. The use of calcium is often limited by hypercalcemia. Aluminium compounds are effective, but can cause toxicity as a result of accumulation. Sevelamer hydrochloride is a relatively new treatment that reduces these problems, but it is expensive. Alpha-calcidol or calcitriol corrects deficiency in activated vitamin D. Its use may be restricted by hypercalcemia, and it also tends to increase plasma phosphate. Cinacalcet stimulates the calcium sensing receptor, leading to decreased PTH secretion. NB. Foods high in phosphorus: milk, eggs, cheese, yogurt, cream. Anemia. In renal disease, the renal cortical and outer medullary fibroblasts produce less erythropoietin for a given hematocrit. Consequently, the hemoglobin set point falls as GFR falls. The resulting anemia is normochromic and normocytic. Always consider other contributory factors, e.g. iron deficiency or ongoing inflammation. Consequences include fatigue and left ventricular hypertrophy, LVH. Treat with recombinant erythropoietin, which is usually not necessary until creatinine is above 350 moles/L. Aim to maintain hemoglobin above 10.5 g/dl. Cardiovascular risk and LVH. There is high cardiovascular mortality in those with CRF, even after correction for diabetes, age, sex, and race. It is at least 10 times greater than that of the general population once end-stage renal failure has been reached. Probable etiological factors include hypertension, dyslipidemia, and elevated homocyst, E.INE. LVH is an independent risk factor for cardiovascular mortality and, as renal impairment progresses, the percentage of patients with LVH rises to 45% when GFR is less than 25 ml/min. Major factors are hypertension and anemia. Treatment strategy. This should include the following: attention to other cardiovascular risk factors, smoking and exercise. Meticulous treatment of hypertension, also important in preventing progression of CRF. Possibly a lower threshold for preventive measures, antiplatelet agents, lipid-lowering drugs, and folic acid. This may be appropriate, but is not proved. Potentially these interventions could also influence the progression of CRF, based on animal studies. Human studies are in progress, e.g. study of heart and renal protection. Gout. Gout is common. Reduced urate excretion and diuretics are the major factors. It is often confused with pseudogout, pyrophosphate. Generally, treat acute episodes with colchicine, avoiding NSAIDs. Prevention is with allopurinol, if urate is high or after an episode. NB. Remember to reduce the dose of allopurinol in those with renal impairment. Pregnancy in chronic renal impairment. As renal function declines, so does the ability to conceive and to carry a pregnancy successfully. In some women with chronic renal impairment, pregnancy results in additional deterioration in renal function superimposed on the predicted course of their chronic renal impairment. The chance of successful fetal outcome and risk to maternal renal function can be stratified on the basis of renal impairment, hypertension, and proteinuria. Normal pregnancy is rare with creatinine greater than 275 moles/L. Drugs. Dose adjustments are required for many medications. Take care to avoid nephrotoxic drugs. If in doubt, consult the British National Formulary. Preparation for renal replacement therapy. Once it is clear that the patient will develop end-stage renal failure, preparation for renal replacement therapy should be made well in advance, e.g. formation of arteriovenous fistula for hemodialysis. You should also consider whether a transplant would be appropriate before the patient reaches end-stage renal failure. Prognosis. The effect of chronic renal impairment on morbidity and mortality is uncertain. The tendency to progress correlates closely with the following: amount of proteinuria, amount of interstitial damage on the renal biopsy, higher in men than in women. The likelihood of end-stage renal failure obviously increases as functional reserve decreases. The most useful guide is the trend in GFR.